This documentation module focuses on goals and writing goals that include the what, how much, and why. All of the documentation requirements and guidelines are found in the Medicare Benefit Policy Manual. Manual 100-2 includes more than 20 chapters, and Chapter 15 is the one that describes what is required in outpatient PT, OT, and speech therapy documentation. The chapter, however, is named Covered Medical and Other Health Services, so when you go to find it, look for that one, and then go to Section 220 and 230 where you will find the therapy guidelines. National Government Services is the local Medicare administrative contractor for the state of Illinois. There you can find more guidance on its website. They have published a local coverage determination for outpatient PT and OT services, which all Part B providers of therapy in Illinois should be aware of. So throughout this module, there is additional guidance included from it. I did not include the web link for NGS because it is too long. Google search NGS for Illinois and you will be able to find it. All goals should be written in measurable, objective, and functional terms. Include the functional levels or safety levels that the patient is expected to achieve upon discharge. Give consideration for the discharge environment. Include how much assistance will be needed. Include any supporting criteria or the conditions for achievement. Have a time frame. And mostly, keep the goals patient-centered. Goals should attempt to answer these 4 questions. Who, which is the patient, what, the task, how much, the level of assistance or independence, and why, the functional outcomes. First is the who. Start every one with the patient will be able to, or the client will be able to. You want to avoid goals that become checklists for the therapists. These usually start with words such as assess, or obtain, or evaluate. Remember, those are things that would likely be in your plan because you still need to do them. The what is also fairly straightforward. Is it gait or transfers, pain, an Oswestry score, a care connection score, range of motion? Avoid making goals about generic ADLs, but try to put specifics in there. The objective is hard numbers, not soft guesses, not subjective, not anything that would not be universally known to all people. So avoid increase, but increase to what? Avoid improve, but attain the level of what? Remember, it makes it easier to show progress and write notes if you know what it is that you're working for. Then the why. This is the so what of it. If it doesn't improve function in some way, then you have to ask whether it matters. We have to be able to show that we are positively impacting the patient's functional level. So the goals provide a roadmap for you to reach the functional outcome. That we're going to be looking at some specific examples from Rock Valley documentation that will hopefully help. It is true that Medicare only requires long-term goals, but it is always a good idea to think about including some short-term goals, especially when your plan of care is written for more than 6 weeks. This is so you can show incremental progress and know if your plan of care is working. National Government Services says that long-term goals should pertain to the functional impairment findings documented in your evaluation, reflect the final level the patient is expected to achieve as a result of therapy in the current setting, and be realistic. Show that you have a positive effect on the quality of the patient's everyday functions, and be function-based, so they're written in objective, measurable terms. This is an example of a Rock Valley chart. The goals here are generally objective. You have a reported improvement of subjective complaints from pain. You have the patient will be able to perform step-ups. The patient will be able to return to golf. But in number 3, patient to demonstrate an improvement in walking quality and tolerance. That one is pretty subjective. What about the walking quality or tolerance? And in this particular example, for a total knee patient, there was no assessment of gait at all. There was no balance test or objective gait tests. Those are other ways to be sure to make your goals objective. This is another patient with pretty good goals. an improvement in functional assessment score, Care Connections, to an 80. Now, it's unclear why 80 was chosen. Instead, if 100 is best, then why was 80 chosen? So that would have been good to include. The patient will report a decrease in low back pain, an improvement in lumbar flexion and extension to 65% of range, and then left hip strength. Now, of course, it would have been good to include some activities of daily living in here, because again, that gets it all back to function, but they are objective. Now, realizing that Care Connections may have some objectives, may have some ADL references in there, it's always good to pull out some specific ADLs, just to make it clear that that is what you're focusing on. Now, this patient's problems for a left total hip are listed here. Difficulty with walking, workability, personal care, ADL performance, stairs, loss of motion, stiffness, and standing. However, when you look at the goals, they're not all objective and measurable. So you have an improvement in Care Connections and subjective complaints, but again, we have that standard goal of improvement in walking quality and tolerance, but it's not objective. We have a good gluteal contraction to 4 and independence and compliance with a home exercise program. But over here in our problems, we have difficulty with personal care. It would be good to have a goal for personal care. We have indication that the patient has difficulty with walking, but we don't have an objective goal to measure if walking is improving. This is all based on the therapist's determination of whether there's been an improvement, and there's no guarantee that the same therapist is going to be seeing the patient week over week. We also don't know why a 58 out of 100 was chosen. Is that because there are certain things in the Care Connections Functional Index that the patient will not be able to do because they weren't able to do them prior to? Those are nice things to explain. Here's another example of a patient with a peroneal tendinitis or pain in the right ankle and joints of the right foot. Again, here's some good goals. We have 10 plus degrees, and we explain why that's important. Walking fluidity, proper heel to toe pattern, tolerating 30 minutes or more of gait so that they can return to doing specific home chores. We have a 5 out of 5 ankle strength, specifically eversion, and that's tied to a functional task of navigating stairs. Also, they can assist in return to home and community stairs. And then we have an example of why 30 minutes or longer of pain-free walking is important, because this patient needs to shop. So those are all examples of how we have some goals that are objective and measurable and are related to function. Now, this patient also had some issues with balance, so it would have been nice to have a balance goal, but again, these three are very nicely done and include a lot of elements that the patient was having difficulty in. So I hope those examples are helpful. This concludes the module on goals.